Good afternoon, everybody. I'll be talking to you about COVID in pregnancy. I'm grateful to MedTalks for giving me this opportunity to do my presentation. I have been in the field of gynecology for the last 35 years, and I have been the Secretary General of the Federation in the past, and presently I am the administrator of the Foxy Manyata project. I would be sharing my whole experience about the COVID, and I would like to give you an overview of this. Uh, just, I'm sure that you learned a lot from all other experts, but I would like to give you some understanding that COVID is a RNA bat virus. It has got 96% similarity to the bat virus. It is from the genus Beta coronavirus, family Coronaviridae, and the virus has crossed two species before it fell. The name corona comes from when if you look at the virus under the electron microscope, it is like a circle with spikes, and hence it is called like a solar corona, and hence the name coronavirus. There are a lot of coronaviruses that have been discovered over the years. The common cold was discovered in 1960, then came the MERS CoV in 2012, the SARS was discovered in 2019, and this particular virus is similar to the SARS virus, and hence it's called the SARS-CoV-2 virus. As it is new to humans, it is called novel virus. And WHO on 11th February 2020 gave it the name of coronavirus disease of 2019, and the acronym for that was COVID-19. If you look at the etiology, this virus is a trimeric glycoprotein spike. It has got spikes, and this spike is trimeric glycoprotein. It is called S spike, and it is made up of two parts: the S1 part with ABCD subpart, and the S2 part. The S1 attaches to the angiotensin converting enzyme ACE2 receptor, which is present on the cell surface of lung cells. Following this, the S2 triggers a chain that enables fusion of viral and cellular membranes, resulting into the entry of this virus into the cell where it replicates, proliferates, creates a new nucleocapsid, and it releases the virions into the exterior by exocytosis. This virions will infect other cells, and that's how the cycle continues. The virus may also prevent the attachment. Recently, what we have found is that it may prevent the attachment of heme to iron, that is a ferritin, causing decreased uptake of oxygen, and that's why many of these patients need a lot of oxygen, and if you see, the lungs get opacified because of that. And many of the treatments which we will evolve, the antiviral antibodies, are very target receptor binding specific, and they are very specific to each of the virus. If you look at the community spread, it started in Wuhan on 31st of December when WHO declared it as a pandemic, and it originated probably in the Hunan seafood market in Wuhan. It is called a SARS-CoV-2 as it is 70% genetically similar to the SARS-CoV virus, and that's why it's called the SARS-CoV-2 virus. On 6th April, as on yesterday, on 8th April, 1.4 million people have been infected as on yesterday night, and nearly uh, there are nearly 82,000 deaths with a mortality of 5.8%. I have shown in the figure, in the bracket figures in India: 5,351 infections, 160 deaths, and so we have a mortality rate of around 3%. In India, the infection is by the upper respiratory tract through the ACE2 receptor, as I had already told you, present in the lung cell. Normally, there's an asymptomatic period which may last from 2 to 14 days, but the mean period of asymptomatic is around 5 to 7 days. When the around 5 days after the infection enters the body, the symptoms start. If you look at the infectivity, you need to ask for travel history. You can have a contact with a person having the disease, but a lot of carriers are asymptomatic, and these are the super spreaders. It can also be a lot common in the healthcare workers, as we are seeing now. A lot of doctors and nurses are getting infected. Infectivity may be from day 0 till day 28. The highest is from day 7 to day 21, and we would call it, that patient is cured 72 hours after the symptoms disappear, or two consecutive RT-PCR tests are negative at 24 hours in interval. If you look at the community spread, 30% are asymptomatic patients. However, these are infective. Remember, even though they are asymptomatic, they are infective, and this is the problem of super spreaders. As it had come in the newspaper just today that one person can potentially infect nearly 400 plus people. By creating a lockdown, that can be reduced drastically, and that's why the indication of a lockdown. 55% have mild symptoms, 15% have severe symptoms that need oxygen support, and 5% have severe symptoms which include acute respiratory distress syndrome, which may need ventilator support and prone ventilation and ECMO, etc., etc. The symptoms are commonly fever in 88%, dry cough in 68%, dyspnea in 19%, sore throat in 14%, diarrhea in 4%. Some 5% may need ventilator support, and in recent times, a lot of people are presented with abnormal smell, abnormal taste also, which can be manifestations of the infection. As I told you, period of infectivity is throughout the duration of the illness till two PCR samples 24 hours apart are negative or patient is asymptomatic for 72 hours. If you look at the mortality rates, with MERS has a 37% mortality rate, SARS had a 9% mortality rate, while COVID-19 has around a 5.4% till now mortality rate. More males than females are there in the world affected. If there is an increase in age, as you can see in this US study, less than 19 years, hardly 0% mortality was there. While as the age advances, more than 50, I think is a 50 is a cutoff. 50 with comorbidities or 50 with, I feel is the magic figure is 50 years of age. 50 years of age are the people, more than 50 are the dangerous people. If you go on ventilator, the mortality ranges from 50 to 85%. And if you have comorbidities like diabetes, hypertension, heart disease, obesity, lung disease, you may have a higher mortality. In healthcare workers, the viral load is huge, and that's why it is advised that you should not have more than 6 hours of exposure. And many of the healthcare workers need to be given a break from their duties, and so that the viral load goes down. Patients on antihypertensives may be having some danger, but not really. If patients have high SOFA score of more than 5.6 or a high D-dimer level of more than 1 microgram per ml, can have a higher incidence of mortality. There is a decrease in mortality in areas endemic with malaria, like maybe India. As we are seeing, the mortality is not yet still high, and those which hydroxychloroquine. Foxy is Federation of Obstetric Gynec Societies of India. We are 37,000 plus members. I was the past Secretary General of the Federation and presently of the administrator of the Foxy Manyata project, which normally is aimed at upgrading nursing homes. And Foxy under the present President Dr. Alpesh Gandhi and the present Secretary General Dr. Jaideep Tang had, and including 2,000 gynecologists, including myself, we came out with a Foxy advisory and Foxy GCPR on COVID-19, and that can be easily seen at the site www.foxy.org. So you can go there and you can go through that. It's a detailed, very beautifully made GCPR. However, I would like to summarize it for you. So if you look at the prevention and treatment of asymptomatic pregnant mothers, survival is 3 hours in, the survival of this virus is 3 hours in air as droplets, 4 hours on copper, 24 hours on cardboard, 72 hours on metal, and hence social distancing, at least 3 to 6 feet distance is very good. The 5 principles of prevention are staying at home, distancing, hand hygiene, using a face mask, using proper respiratory hygiene. And it's very important, if you look at the cleaning of surfaces, because it transfers by droplet, you need to clean surfaces, and you can kill the virus by the various modalities. Like if you have the virus at 70 degrees centigrade for 30 minutes in dry heat, if you want to sterilize your face mask, for example, N95 mask, you can put it in a dry heat, sterilize for 30 minutes, and it will destroy the virus without destroying the fabric of the mask. UV light for 30 minutes, or 0.1% bleach for 5 minutes, soap or water, or 70% alcohol for 5 to 10 minutes. And you should avoid touching fomite. So if you have got comes from outside, you can keep it in one corner for 24 hours, clean your hand after you touch the fomite, and later on, 24 hours later, you can use to open the parcel. You can also disinfect the parcel if you want with alcohol. The quarantine period in this is around 14 to 28 days. Some states like Kerala are having a 28-day quarantine period. If you look at the treatment of asymptomatic pregnant mothers, you need to try and minimize. So if there are, during this time of COVID, if you have got a patient, you try to minimize trying to call her to the antenatal OPD, because we are looking at social distancing. And so there should be minimal antenatal visits, home monitoring of weight, blood pressure, fetal movement, and you should have a ultrasound only at 12 weeks and 18 weeks, which is important to rule out fetal anomalies, antenatal visits should be deferred otherwise, and only a 32-week visit should be done. We should avoid, there is a normally traditionally in our country at 7 months, you have the Godh Bharni type of thing. And so you must avoid that 7 month milestone and minimize visitors post delivery, during delivery as well. Prior informing the doctor. So the patient should inform the doctor prior to the antenatal visit. If she is symptomatic, she has got fever, she has got cough, cold, she should inform the doctor. So proper precautions can be taken receiving the patient in the OPD. Testing of the patient should be either by RT-PCR or by the rapid antibody test. CT chest can be done by using an abdominal shield to shield the pregnancy. And what are the patients you should test? Patients with severe acute respiratory illness, which is called SARI, cough, sore throat, fever, difficulty in breathing, or shortness of breath. Pregnant women, especially those with associated medical diseases like diabetes, asthma, etc., may present with pneumonia and marked hypoxia. Instead of cough cold, they may present as pneumonia with marked hypoxia. And of course, if patient has got a 14-day history of travel or contact with positive patients, so these should be tested. But my corollary to this is that in the future, when we are doing the surgeries on symptomatic patients, we will have to test them before we take them up. So if you look at this beautiful chart, at zero, when at least the infection is at zero, the viral one minute. So if the infection is at zero, the viral antigen is there at around the 7th day. The IgM starts on the 9th day. The IgM will come into the blood, and around the 14th day, the IgG level will start rising. So based on this, you can actually interpret the test result. You can see that Ig, the viral antigen, will go down at to nearly 28 days. So 0 to 28 days can be a huge period of infectivity for the disease. So if you look at how do you treat a COVID positive pregnant woman? So we need to isolate the patient if she's got mild to moderate disease. Isolation, according to me, should be in the level 1 hospital or in the house. You can do it, but in the house there is a high chance of you giving infection to other patients. So it's better to isolate them in the hospital. You should admit patients who need oxygen support or ventilation support along with concomitant medical management. Like in flu, pregnant patients with flu, the pregnancy can get aggravated. The disease can aggravate the pregnancy, and the pregnancy can aggravate the disease. But this has not been found in the COVID-19 patient. There is no increase in preterm birth. There is no increase in risk of miscarriages. Neither there is an increase in the risk of bad outcome. If patient develop disease in the first or second trimester, there is not much harm to the patient or the fetus in majority of the patients. In patient more than 28 weeks, if the day develop disease later, then more care needs to be taken because they will not develop immunity. And when they are birthing the child may have a higher risk in the breastfeeding period. The disease. If you look at the medical management, I don't have to go through it. Mild and moderate cases, oseltamivir along with paracetamol and azithromycin for mild cases. And if the respiratory rate is more than 24, oxygen saturation falls below 94, there's confusion around drowsiness, which may indicate encephalopathy, neuroencephalopathy, or a hypotension BP less than 90/60, then you may start hydroxyquinoline along with lopanavir or ritonavir. All so many expert medical people are there. You can manage the patient medically with a physician or an intensivist. Coming to the labor, when the patient comes in labor, what are the things that you would do precautions? Women should call in advance to alert the maternity unit about her arrival. This will give some time to the healthcare worker to prepare the PPE suit because she has to be received in a PPE suit. She has got a COVID infection. She should be met with appropriately donned PPE at the reception itself, and one should keep the room free from unnecessary items because this can be a source of fomites later on. There should be restriction to the number of attendants. The birth attendant should also be only one, and there should be no history of that birth attendant having any fever or exposure or contact or history of travel. Room should be the presence of infection is not an indication to induce labor or deliver the women. So if there is infection, doesn't mean that you have to deliver her or induce labor. You have to measure just like any other normal patient. And cesarean should be done only for severely ill patients. Suppose there's a huge metabolic load, then only you may do a cesarean. Although there are a lot of papers that have come out on COVID pregnancy, right from Wuhan and from United States, but in that there is a higher incidence of cesarean rate. Majority of the patients have been delivered by cesarean section, but they were not delivered because of COVID per se. They may have been delivered due to other reasons. Avoid tocolysis, especially with beta mimetics, because that can aggravate the situation. Isolated labor room with all facilities of ICU, HDU, ventilator should be available in the hospital. PPE must be there for all, and there should be minimum personnel in the labor area, and the birth attendant also should be having PPE on. If you look at the room, there should be standard protocol of monitoring, respiratory rate, pulse oximetry, minimize intervention. There should be no water bath being done. IV fluids, electronic fetal heart rate monitoring should be done. You should cut short the second stage of labor. It's very important to cut short the second stage of labor. And cesarean section is then only for obstetric indication. Very rarely for severe disease, there may be additionally cesarean done. Delayed cord clamping has been recommended by RCOG because there is no history of any transmission of infection to the fetus in this patient. As far as the operation rooms is concerned, we need to design the OT with a negative pressure. We need to have barrier between gynecologist and patient. When you are operating, you should have a cloth barrier so the patient doesn't directly breathe. And if patients are under spinal anesthesia or epidural, you must give them a face mask so that the breathing is controlled. There should be minimal personnel and movement. Regional anesthesia, as I told you, epidural or spinal is very important. And GA, if at all, we should give with care. It is very important to have post-operative isolation and barrier nursing. If you look at the anesthesia, for most women, spinal should be used. But in certain situations, there may be a need for general anesthesia. If at all general anesthesia should be administered, the patient should be pre-oxygenated for 5 minutes with 100% oxygen. And we should perform a rapid sequence induction to avoid manual ventilation of the patient's lung. Preferably a video laryngoscope may be used for intubation, and we should avoid awake fiber optics intubation when possible. This is a procedure that induces aerosolization and we should avoid it. The need for using full PP is very much there. Place a high efficiency hydrophobic filter between the face mask and breathing circuit, or between the face mask and reservoir bag to avoid contamination of the atmosphere. Is there any effect of COVID on fetus? The infection is not transmitted from the mother to child by placental transfer or throughout secretions of the genital tract. There have been 2 reports, including total of 18 patients which were having suspected or confirmed COVID-19 pneumonia, and all of the pneumons were delivered by cesarean section, and they all tested negative for the coronavirus, and there was no traces of the virus in the mother's amniotic fluid, cord blood, or breast milk. There have been recently few of the babies being tested positive, but overall consensus is that the children, the babies born have no infection, and you can definitely give them breastfeeding. So if you look at the care of the newborn, at present testing is recommended. So if the mother has COVID-19 infection, naturally a baby should be tested after being born, or if the baby is symptomatic. And breastfeeding can be given with good hygiene practices. Rooming in may be done unless other is severe. In severely ill patients, breast milk may be expressed and given from, or milk can be given from milk bank. Postnatal care and advice to the mother infected with COVID-19 should follow routine practices. If the woman is isolated from the neonate, she should be offered psychological assessment and support. This was a joint ASRM AHL ECOG statement from United States, and this was on 6th April 2020, where they advocated that you should cancel all elective and non-urgent procedures to conserve resources and increase hospital capacity to provide critical care. OB/GYN procedures for which delay will negatively affect and safety should not be delayed, like severe PI, APA, delivery, abortion, ectopic, ovum pickup, ERT in situations like fertility preservation for cancer, older patients with poor ovarian reserve, cancer surgery you can do these surgeries because they are not elective, they may be necessary. And there is a chance that the guidelines keep on changing as we evolve and we tackle this disease. What are the precautions while doing IVF, for example? One should postpone elective work like ovum pickup and embryo transfer if ovarian stimulation has not started. However, if it is started, you need to complete the cycle. there is a controversy of whether infertility treatment is elective or not urgent, and this controversy will be settled down. The ASRM is coming out with a statement on 13th of April, and later on we can decide whether postponing infertility treatment comes under elective or urgent. Completion of already started cycles by freezing eggs and embryos and avoiding transfers, as we don't know effect of COVID on surgery as well as on pregnant fetus in the long term. That's why if you try to avoid, you can freeze the embryos and then you can transfer at a later date. Gametes do not have any COV receptors and are protected by zona pellucida, egg, sperm, or embryo. They don't have SARS-CoV-2 receptor, and proper precautions should be taken to avoid COVID by mainly adhering to proper laboratory practices and safety principles of repeated washing step, which will cause high dilution of contaminants. So you keep on, suppose there's an embryo transfer, you repeatedly wash it multiple droplets so that even if there is a possible contaminant virus, it will get so much diluted that when you are freezing the embryo or when you are transferring the embryo into the uterine cavity, you don't transfer the virus along with the embryo. What about endoscopy? One should avoid performing aerosol procedures. So you must check the trocars before you put them in and create a pneumoperitoneum, because pneumoperitoneum creation and decompression of the pneumoperitoneum can generate aerosol. So you must decompress pneumoperitoneum by taking the CO2 out through a closed circuit evacuation system which goes through a filter. Even if you are doing cauterization intra-abdominally, there will be smoke generation. The smoke should not be allowed to escape. You must suck it out by a closed circuit system, and that is how you must prevent the aerosol generation. If there is no way, then you better to do an open surgery rather than a laparoscopic surgery. As far as the hysteroscopy is concerned, there is no risk because we are doing it under saline control, under kind of thing, and there is no possibility of generating any smoke. I will not talk about the primary protective equipment. I'm sure they must have talked to you, but the general principles have to be followed. Body suit of 3 layers, protective glasses with cap or face shield, N95 respirator, along with a surgical mask on top, 2 layers of gloves, and boots with cover should be used. So there are a lot of newer treatments, and I'm sure Dr. Agarwal must have talked to you about it. There are 41 diagnostic tools being researched, 23 treatments in clinical trials, 5 vaccines are in clinical trials, single dose of ivermectin may be effective, Favipir improves lung function, that may be effective, hydroxyquinoline may be reduced symptom duration. These are a lot of talk, and few now experiments have been done by extracting the antibodies of already exposed and recovered patients, and these antibodies can be extracted by plasmapheresis and be given to the patients who are on ventilation and can be salvaged. So now come to the more important thing. What is the good part? We are saving lives. We are in the front line. The COVID warriors we are called. We will be respected and I hopefully remembered for our work and sacrifice. Healthcare and health expenditure outlay will be increased, I'm sure, by the government after this epidemic, till they forget about it later on. Public memory is short. After a few years, they'll forget about the epidemic and will maybe go back to square one. And many investments will be made in the healthcare industry. What is our future bad part? So I was looking at it. I have been reading about this a lot. My father was the director of family planning. He was a professor of preventive medicine from Harvard. And when I was a young child, my dad had tackled the whole cholera epidemic, which had been in Mumbai. Since then, I have been exposed to preventive medicine. And as I was thinking about it just now, 2 hours back, I have gone to the net, and I feel COVID-19 is exactly following the footsteps of the sweating sickness of the 15th century, where people used to die in 12 hours. They used to sweat and die. And King Henry actually stayed in his castle for 2-3 years. He never came out during the outbreak. He socially distanced himself and he saved himself from this outbreak in England. And one day, after 3 years, suddenly the sweating sickness appeared. Same thing happened with the Spanish flu. I was reading about it. In the 1918, the flu started in Mumbai and it spread rapidly. The first wave finished in June. The second wave started in September and it finished mid-March of 2019. And then there were a few more waves, and ultimately the Spanish flu disappeared in 1920. So it took so this kind of wave will take minimum 2 to 3 years to go away. By the time vaccine comes, herd immunity is developed. So there we need to tackle. So sudden mental, possible physical, including 1% chance of mortality is there. Many of us are more than 50 years of age, and we have comorbidities, and we may have also economic decision. We have to say that majority of the gynecologists are women, and so mortality may be less, but overall there is going to be economic disruption. And as I told you, we are looking at a 2-year window. It's not a 2-month window, it's not a 6-month window, it's a 2-year window. By the time we come back to our original phase of life that we are in, original phase where we had kind of economic stability, we are going to go through a lot of turbulence and come back to that point 2 years down the line. So in the immediate present, you and your hospital staff must get COVID. If you get COVID positive, your result will, what will happen? They will seal your hospital, etc. So this is happening with a lot of our colleagues. And you are staring at, as I told you, a prolonged lockdown and possible continuation of the pandemic till a vaccine is launched. This may result in a long-term financial downturn. So we have to look at it economically also. We will have to. So what is it we do? So there are 3 things we do. Changes in our consulting rooms and OPDs. Decrease contact by digital online consultation. You minimize clustering by giving appointment. Each patient should be asked for history of COVID, contact, history of SARI symptoms, and tested for temperature at entry to the clinic. Patients and relatives should, and not more than one relative should be avoided, should be made to sanitize their hand and given a simple surgical or cloth mask to wear when they are consulting you. Education of or distancing, sanitization should be given television or pamphlets when they're sitting in the waiting area waiting to meet you. You should keep, when they come into your clinic, you should keep a 1 meter distance between yourself and the patient. I also feel that you should keep 1-2 meters, and you should have ventilation. You need to change your consulting room air conditioner because it should have more ventilation, and you should wear a N95 mask, glasses, face shield, or gloves are must when you are consulting the patient. What about your indoor hospital practice? Upgrading your facilities. You sign up with Foxy Manyata program, will upgrade your facilities. Decrease clustering. You should have single rooms for all, maybe. The good old days of common rooms should be maybe given up. Single room for all, or if you have a common ward, it should have a lot of ventilation and spacing. You need to relook at air conditioning and ventilation. You need to refit your operation theater with air handling unit with disinfection ability like UV light, catalytic converters, and negative pressure. So it will kill the virus. Otherwise, if there is a closed circuit air in your operation theater, it's going to infect you someday or the other. You should do proper history taking and aggressive testing. So every patient you operate on has to be tested in the future. There is no way out of this. Routine pre-procedural testing has the must for all, routine precautions for all, and aggressive use of disinfectant. 0.1% bleach you should, even नींद में उठ के भी आप 0.1% bleach का इस्तेमाल कीजिए. You should wear proper PEP, and there should be a proper waste disposal process. And changes in your day-to-day practice. You should have one pen, phone, water bottle, pack food when you leave your house, leave in the car. You should cut your hair. In most of my colleagues are lady gynecologists, so if they have big hair, it may be difficult to wear the PB to shorten your hair. There should be no jewelry. You should avoid going by lift. If at all you're going, you should not have too many people in the lift. Don't touch anything. Clean the surfaces of handles and cars and consulting room. Wear mask, goggles, washable footwear. Use washroom and or diaper. Sometimes if you wear a PPE, you may operate for a long time. So you must wear a diaper if you think that you can't use your washroom for a long time. Because once you don the PPE, you can't take it out and in and out and all that. Inform while returning home. When you return home from hospital, you inform in advance. House people will keep things ready. As soon as you enter your house, clean your hands, remove your footwear, place it in one corner, remove clothes for wash, clean your mobile phone, etc., and take a bath. And keep your social distance even in your house. So in lifestyle change, enjoy your life in real time. Do long-term financial planning. This is a 2-year jhatka for all of us. So you must do long-term planning, consolidation of practice. You must do human handling of workforce. You may have to do pay cuts, layoffs, but do it humanly. Conserve the resources and savings. You must conserve your savings. Go back to school. You need to learn again, relearn yourself. Maybe create newer business. We doctors are all intelligent people, and we need to create avenues of income for our houses. Creating new business streams are very important. So I will end this talk by saying what Steve Jobs said. He's no more now, late Steve Jobs. I used to be a great admirer of him. You can't connect the dots looking forward. You can only connect them looking backward. So if suppose 10 years later, when you are reached your career, you look backwards, you say, Acha, I did this, I should have done that. But at the time when you were doing that, there was no way you would know the future. So you have to trust those dots, which will somehow connect you to your future. So when you are doing this all, fighting the COVID, you have to trust your future. You have to trust in something, your gut, destiny, life, karma, whatever. And I hope that all of you will trust someone and trust our God, and we hope to battle this disease and come out successful on top. Thank you very much. Thank you, Dr. Agarwal. Thank you, Meditalk, for inviting me to give my.
Thank you, Dr. Rishikesh, for your wonderful presentation. There's a key message. Good news is that this corona is a novel virus. So far, whatever we know, and you have spoken about the updates, in a pregnant women are considered to be a high risk group. And so far, there's no scientific evidence to state that COVID infection has adverse effect on delivery or on the fetus.
Right.
And main key message is there is no, as on date, scientific evidence of transmission of a maternal to fetal transmission of COVID infection, and breastfeeding should be as normally should be given. And COVID infection is not an indication for any cesarean section apart from normal whatever indication for otherwise without COVID infection we get. Thank you very much.
Thank you, sir. Thank you.